Jen Shanholter, and I'm going to be presenting to you current issues in maternal newborn care, cultural considerations, and complementary and alternative therapy. Here are the topics to be presented. Clinical practice specializations. There are various nursing options that collaborate to provide comprehensive care to the childbearing woman and her family. The professional nurse and the certified nurse are most often found in the hospital setting. The certified nurse is an RN that has taken a special certification exam to show expertise in a particular area. Maternal newborn nursing has many certifications, and some of the more common ones are inpatient obstetrical nursing or neonatal intensive care nursing. Many of you in your clinical setting have worked with certified nurses. Advanced practice nursing, such as a women's health nurse practitioner or certified nurse midwife, likely work in obstetrical or gynecological practice. These nurses are specialized to an area and provide comprehensive care to the patient. They work somewhat autonomously, but ultimately they are under a practicing physician. Many of you in the clinical setting have also seen certified registered nurse anesthetists, or CRNAs. These CRNAs typically are under the direction of an anesthesiologist. The American Association of College of Nursing, or the AACN, has recently changed the required education of the APN from master's degree to DNP, Doctor of Nursing Practice, and this does take effect in 2015, which does affect you. The healthcare environment. Healthcare in the United States is a political issue. Many Americans still do not have health insurance, and most of these people who don't have health insurance are under the age of 65. So although we spend more money on healthcare, we don't necessarily have better statistics. The healthcare environment certainly affects prenatal care and can prevent women from seeking prenatal care, which can lead to adverse pregnancy outcomes. Preventative care and health promotion improve outcomes and decrease healthcare costs. However, not everyone, and especially minorities, have access to prenatal care. Only 70% of women received prenatal care in their first trimester. Now, many of you have heard of Healthy People 2020, and these set goals for the United States. And some of the objectives for maternal, infant, and child health are to have a 10% increase in women receiving prenatal care. If you'd like, you can check out our objectives at healthypeople.gov. Legal considerations and ethical issues. A big one is abortion. We all know the GTPAL. A stands for abortion, and in the medical world this could be a spontaneous abortion, such as a miscarriage, or a therapeutic abortion. Now, when we talk about abortion out in the public, people think of the therapeutic abortion, which is an induced abortion. In 1973, Roe v. Wade was a big Supreme Court decision that legalized abortion in 50 states up until viability. This is still a very controversial issue. Viability is not defined the same in each state. Also, we must remember that women can be having abortions for different reasons. For instance, some fetuses may be incompatible with life, or maybe it's a concern for the mother's health to carry the pregnancy. Also, on a more emotional side, a woman could have been a victim of a rape or incest. In these cases, it's still considered a therapeutic abortion. I can actually remember caring for a woman who had a 13-week gestation pregnancy that was incompatible with life. It was a severe trisomy 18. She came into the hospital under an alias to induce delivery. She was unable to tell anyone in her family except for her husband, so not telling her parents, not telling her siblings what she was going through because they were very pro-life. However, she had young children and felt that it was important to not get them caught up in the excitement of pregnancy and then having to deal with losing a child. So, although she was having an abortion, it may not be what you've always thought of abortion. It was a very difficult time for this patient, and she felt so guilty for lying to her family. And this goes to show how important it is that we understand our patients and we give them unbiased, supportive nursing care. We don't necessarily agree with all the choices of our patients all the time. Note, people do have a right to refuse to assist with abortion, as it can be against their moral or ethical beliefs. But as an employee, it may be a requirement of your job, so finding this out before you join a job is your priority. It's important that you understand your duties as an employer. Also, nurses by law must never abandon a patient and should ensure that caring for a woman having an abortion, that she is getting appropriate care. Caring for your patient may not be a platform for your personal or political views. On a side note, there is a mandatory 24-hour waiting period, and counseling must be provided to these women making decisions to have abortion. Intrauterine fetal surgery is typically done in the second trimester. It involves opening the uterus and performing surgery on the fetus, and then replacing the fetus back in the uterus and repairing the uterus. Sounds extensive, and it is. It's done for fetuses that typically have a situation that's incompatible with life. An example of this type of surgery might be bladder outlet obstruction on a fetus, which could be recognized by a fetal ultrasound. In this case, the fetal bladder is unable to empty, causing major problems. Surgery can be done, and they can put catheters in to drain the fetal bladder into the amniotic sac. And this type of surgery would be done in a fetal treatment center, such as Cincinnati Children's Hospital Medical Center, which is one of the closest ones to here. This surgery is obviously risky for the fetus, and it poses risks to the mother as well. Families must consider these risks and benefits and make an informed decision that is right for them, not necessarily seems right for us. Okay, embryonic stem cell research. Embryonic stem cell research is controversial because the embryo, is it someone's property or is it a person? Also, what is the source of the embryo? Is this from cloning, and is that appropriate, or is the embryo left over from fertility treatments and it wasn't necessarily used? They found that these cells in embryonic tissue can be used to treat things such as diabetes, Parkinson's, etc. Cord blood banking. Collecting cord blood at delivery does not put the neonate or the mother at risk, so that's not the debate. Essentially, it's non-invasive and it's not painful, as collection is done after the infant is delivered and the umbilical cord is clamped and cut. While waiting for the placenta to deliver, a sample of cord blood can be collected using sterile technique from a section of the umbilical cord that's still attached to the placenta. Now, what does get a little more debatable is private versus public banking. Private cord blood banking is expensive with initial costs and then storage fee per year. It is commercialized and it's for profit. It's a business. Public banking, however, is voluntary, and the cord blood becomes a part of a public banking system that can be used by whomever needs it, similar to donating blood. The American Academy of Pediatrics and the American College of Obstetricians and Gynecologists have some recommendations for cord blood banking. Private banking should be encouraged when a biological sibling to the newborn has a condition that would benefit from cord blood transfusion. However, private banking should not be seen as insurance in the case that a newborn develops disease, which is usually fairly rare. Often, the cord blood in such cases is not even be able to be used because it carries some of the same genetic traits that are at fault. Public banking should be encouraged as this can help donate to someone in need. The more variety in public cord blood collections, the more likely chance in finding matches. Also, public cord blood collection centers should have testing done on all donated blood for infectious disease or genetic disorders and have a protocol in place that can be used to notify the family. So knowing this information, can you see some ethical concerns in our current cord blood banking systems? Okay, moving on to some statistical data, which is continuously being collected. The National Center for Health Statistics breaks down birth and mortality rates into different categories, such as preterm birth, which you guys know is before 38 weeks, or teen pregnancies. Information on infant mortality, for instance, differs greatly between the various races. An example of an infant mortality disconnect is that of white Caucasian mothers. The mortality rate is 5.57, and the mortality rate for infants of Black or African American mothers is 12.9. And if you guys want to see some more of this data, you can go to the cdc.gov. The United States actually has infant maternal mortality. The United States actually has a high infant mortality rate in comparison with other industrialized countries. We ranked 30th in 2005. What do you think are some reasons for this statistic? Well, to help you out a little, preterm birth is a major contributor of this statistic. 1 in 8 births is preterm in the United States, or before 38 weeks. This accounts for 75% of the infant mortality rates. And obviously, the earlier the gestation and delivery, the higher the risk of infant mortality. But late preterm infants are at higher risk than term infants as well. Late preterm is defined as between 34 and 37 weeks. Now, talking about viability, you see that's around 24 gestational weeks. But this doesn't mean survivability. It means there's a chance at survival, but at around 24 weeks, this chance is about 40%. What are some of these risk factors for preterm birth? Well, I'm sure you guys could think of a few. For one thing, there's various maternal diseases, such as diabetes. We see diabetes is being much more prevalent in the United States than other countries. Why is this? Also, when we start to look at fertility treatments, in vitro fertilization is in itself a risk factor for preterm birth. But in addition, typically we see these moms with fertility treatments as being advanced maternal age, which is another risk factor. Another risk factor that has to do with fertility are multiples. We've seen huge increases in multiple deliveries. Twins, triplets, we've heard of sextuplets here in Akron, and even we've all heard of octomom. Multiple deliveries, the more babies in utero at a time, the earlier their gestational age at delivery is likely. Twins have an average gestational age of about 36 weeks. Nursing implications for the statistics in maternal-infant care. Nursing implications based on this statistical information help determine populations at risk and the level of care needed for these populations. This data can help hospitals prepare such staffing, equipment, and space. So without these statistics, we can't plan. Okay, evidence-based practice in maternal-child nursing. This is a big topic right now. It's actually the buzz phrase that supports why we do what we do. It's the integration of research and evidence to improve healthcare. This is the opposite of, we do this because we always have, or without substantial rationale. We should be striving to incorporate evidence-based practice into our nursing practice. Some institutions have committees designed to gather and evaluate the research and then incorporate this evidence into practice. This may include improving policies and protocols. If the question comes to mind, why are we doing this? Find out why, and maybe why you should change practice. Ultimately, the point is improved healthcare. If it were your family, would you want the most current and evidence-supported care? Probably. Okay, here's a little case study on evidence-based practice. It's actually not far-fetched, and many of you may have seen it already in the clinical setting. 10 years ago, really, kangaroo care around here was not really heard of. So we have seen various good outcomes from kangaroo care, which are listed. And then imagine that after a vaginal delivery, you have a nurse helping you who immediately wraps the baby up. She says, after working here for 20 years, I know these babies like to be wrapped up snug as a bug. So what would you do in this case? Is this nurse using evidence-based practice? How would you respond in this situation? And do you see a need for staff education based on evidence-based practice? Nursing research is a big part of evidence-based care and practice. Without research, best practices would not be discovered or shared. Nursing research also advances the profession of nursing. Care of a family in a culturally diverse society. Culturally competent care. Culture should be taken into account when caring for families. Having cultural competence, or the ability to appreciate, to understand, and respect various cultures, should be part of the care plan. This will improve healthcare experiences for the family and likely promote their acceptance or compliance with a care plan. An example is an Asian father that's not participating in the delivery of his child, which to us we might be like, well, that's just not right. But in some Asian cultures, only the female family members participate in birth or childbirth education classes. There are cultural considerations that we take into account in maternal-child health. For example, women of Islamic faith or Muslim women prefer modesty. They like to keep everything but their hands or feet covered. Also, no males are to be alone with these patients, and this usually means that there should be no male caregivers, so no male nurses and no male residents or physicians. As the patient advocate, it would be our job then to plan for this care of this patient. Some cultures have specific postpartum routines, such as the avoidance of cold, and these patients may request hot tea after delivery, or even refuse any cold water, even when taking a medication. Some Asian women may prefer to avoid confrontation and avoid eye contact. Answering no to questions may be considered rude, and so open-ended questions are the preferred way of communicating. Jewish women follow kosher diets, but also Jewish women's husbands tend to avoid physical contact with their wife if she is having vaginal bleeding or discharge. And I'm sure we could see how that could be misinterpreted as being unsupportive. Amish women usually take their medical decisions back to their community. Most Amish patients pay out of pocket for medical expenses, and so adherence to medical advice could be based on the fact of expense, or it could be based on religion and community input. Also, Amish families do not believe in baptism, which may be relevant for the patient experiencing a loss. Finally, in many cultures, the primary support person during delivery and postpartum is the grandmother, rather than the father, who is seen as having great wisdom. And for an example of this, I took care of a patient who was older, so advanced maternal age, but in addition, she was a physician. She had a great supportive husband. However, her mother was very wise, and she doted after her, combing her hair and getting her stuff to drink and making sure she didn't get out of bed and bringing the babies to her, and really doted after her, which almost seemed a little strange, being that this patient was very competent and able to take care of herself. But this is the practice of their particular culture, and so although it seemed strange to me, it was perfectly normal within their culture, and I need to be understanding of this. Okay, family types. The traditional family is becoming less common than other types of families about to be discussed. Most families today have dual earners, or both share various household and child-rearing responsibilities. Infertility counts for childless families, and some couples choose to be child-free. Extended families may have a grandparent that helps with household chores, or they may require care and assistance as well. Extended kin families live very near each other and pool their resources. This is often seen in communities such as the Latino community. Single-parent families are actually a growing group. There are about 13 million one-parent families in the United States. Traditionally, this is a result of divorce, abandonment, separation, or death of a partner. However, non-traditional single-parent groups, it's possible that the mother was never married. A step-parent family consists of one of the parents not being one of the biological parents. And in a binuclear family, the biological child is part of two traditional nuclear families in which each biological parent is remarried. Often these children spend equal time in two families. Understanding the type of family structure by completing a family assessment enables the nurse to provide more appropriate care. I'm sure if we pooled most of the people in the class, we would see a lot of these type of families. Okay, complementary and alternative therapies. Complementary and alternative therapies is not as widely used in our U.S. Western culture. However, the internet and increasing interaction internationally has brought a resurgence of complementary and alternative therapy. And this is not necessarily voodoo medicine. We've all probably used some sort of complementary or alternative therapy, such as massage or even ice packs. It's important to note that complementary therapy is a procedure that's used in conjunction with conventional medical practice, whereas the alternative therapy is a procedure or product that's used in replace of a conventional medical practice. Homeopathy encourages the immune response with dilute substances that mimic the symptoms of disease. It's the idea of like cures like. In naturopathy, the human body has the ability to heal itself and return to a state of health. Traditional Chinese medicine is a balance of the energies, and many of you may have heard this called the Chai. Examples of this would be acupuncture or Tai Chi. Mind-body therapies use activities such as imagination, reflection, communication, or relaxation. Guided imagery is an example of this and is actually used in childbirth education classes as a tool that families can use to help the mother cope with pain experienced during labor. Manipulative and body-based therapies. Chiropractic therapy, I'm sure everyone has heard of, is performed by licensed therapists and is covered by some insurances. Massage can be used to reduce stress and tension, increase circulation, diminish pain, and promote immune function. Actually, infant massage classes are becoming a very popular way to teach parents to soothe their infants. They offer these infant massage classes for families with newborns at Children's Hospital and at other facilities. Yoga is also becoming very common. Hatha yoga is the physical exercise to prevent illness, promote wellness, and to promote healing. There are many opportunities for pregnant and postpartum women to take specific yoga classes. Often many healthcare facilities, such as Akron General or Cleveland Clinic, offer these classes that are designed specifically to avoid injury to these pregnant or postpartum women. Hydrotherapy. Hydrotherapy can be used in the first stage of labor, and we can see this woman using hydrotherapy during her labor. It's especially for women who prefer not to have an epidural during their labor. This goes back in time. Use of hot springs or hot tubs have been used to promote relaxation and are common practice. They have been shown to decrease pain, help with coping, and help maintain an upright position, which is good to facilitate labor and therefore, hopefully, potentially decreasing the time of labor. Breastfeeding is another area where complementary therapy can prove to be very helpful for some women. For those experiencing a decrease in milk supply, galactagogues may be used. And most popular here in the United States is the herb fenugreek. This should increase supply of breast milk in 1 to 3 days. This should also be done in conjunction with good breastfeeding practices. Can you remember some of these practices that increase breast milk supply? Well, frequent feedings, which are 8 to 12 in a 24-hour period, increasing maternal adequate fluid intake, and adequate nutritional intake, remembering that there is an increased need of calories, even more so than being pregnant, and decreasing stress for the mom, which can be a real challenge in the newborn period. Cabbage leaves are also fairly common practice to help with engorgement and breast swelling. These should be chilled, and they can even be rolled with a rolling pin to release more of their useful properties. Moms can then place them in their bra and remove them after a couple hours. Although these sound a little bit strange when placed in this position, they may be a great last resort. Examples of nutritional therapy, besides the galactagogues, are the supplement DHA, deoxyhexanoic acid, which is an omega-3 fatty acid found in fish oil. DHA may decrease the risk of miscarriage in some women and may decrease the incidence of asthma in children when taken during pregnancy. Other therapies such as sense therapy or aromatherapy and music therapy can be used by women during labor to cope with pain. The risks and benefits, there's always risks and benefits, right? And usually to most aspects of healthcare. Benefits are that complementary and alternative therapies are usually holistic and focus more on healing versus actual curing. Not all aspects of disease or health conditions can be fixed. Childbearing families should be aware that these types of therapies are not without risk, though. Unfortunately, not all claims are true, and there could be lacking research. Also, these forms of therapy are not always regulated, which could lead to potential health risks. Understanding the use of complementary and alternative therapy used by the patient and the family helps nurses to develop appropriate care. Having a non-judgmental and open discussion with will help families be more comfortable in sharing their therapies that they use. Some therapies can be used in nursing practice. Very often, nurses use many of these reviewed to help with childbirth. And some of the things to keep in mind are to follow the Nurse Practice Act. And usually using mainstream or research therapies is appropriate. For instance, using the tub for labor is appropriate as there is a protocol for having our pregnant women use the tub. You also need to follow informed consent. An excellent resource for complementary and alternative medicine is this National Center for Complementary and Alternative Medicine, NCCAM, which the website is listed here.